first thing to know about liver function tests is that not all of them are tests of the liver's function. About half of them are enzymes released from the damaged hepatocytes into the blood. The other half are actually tests of the liver's function because they're things made by the liver. So let's start with the enzymes. First, we have alanine transaminase. This is just your generic liver damage marker, and you can remember that because the L in ALT can stand for liver in your memory. Secondly, we have aspartate transaminase, or AST. Now this is only released in very serious liver damage because it's stored in the mitochondria of the hepatocytes. You can remember this because of the S in the AST. ALT and AST are sometimes known collectively as the aminotransferases or the transaminases, and that's why you'll sometimes hear elevation of either of those two enzymes referred to as transaminitis. Thirdly, we have alkaline phosphatase, and this is a marker of biliary obstruction because it's released from the canalicular side of the hepatocytes. So when there's blockage of the biliary tree, it backs up into the blood. As an aside, it's important to remember that there are two isoforms of ALP. About 50% is the bone isoform, which is highly elevated in, for example, Paget's disease of the bone, and the other 50% of ALP is the liver version, which we're talking about now. And fourthly, we have the rarely used gamma-glutaryltransferase, or GGT. Now this isn't much use because it's got such a lack of specificity, but it goes up in biliary obstruction and it goes up a lot in alcohol abuse. So those are the four main enzymes in the LFTs. Now we get on to the actual tests of the liver's function. There are three markers for this. First, we have albumin, which is a protein produced by the liver, normally floating about in the blood and providing that oncotic pressure which stops ascites and edema. So, in chronic liver disease, you get those two things. Secondly, we have bilirubin, which is of course a breakdown product of heme after it's been metabolised by the liver. Two main things can cause a rise in bilirubin. First, if you've got a breakdown of lots of blood, as in hemolysis, and second, if there's biliary obstruction causing all of that bilirubin to back up into the blood, where it gets deposited and might cause jaundice and pruritus. And then third, we have prothrombin time. And prothrombin time is a marker of liver damage because the liver produces your clotting factors. Now this is usually given as international normalised ratio, and all that means is it's a ratio of the prothrombin time over the normal average prothrombin time for the average person, and that's because lab values for prothrombin time vary quite a lot. So those are the three markers of liver function. Now it is possible to have decreased liver function but normal liver enzymes in the, say, chronic disease, and that's why it's so important to make this distinction between the enzymes and the actual markers of liver function, even though they're all known as the so-called liver function tests, but there is a move to start calling them the liver blood tests instead because of precisely this actually. So let me give you a few clinical scenarios to think about. These are often known as pictures, which is a poetic way of saying a pattern. So the first one I want to talk about is pre-hepatic jaundice. If your patient's jaundiced and their bilirubin is increased, but all of their liver function tests, apart from that, including the enzymes, are normal. This is a marker of usually hemolysis. The second picture you might see is if all your liver enzymes, your ALT and your AST, are highly elevated, but your liver function tests are all equally affected. This is probably hepatitis. Thirdly, you might see ALP elevated and possibly GGT if you're measuring that too, but the other enzymes, ALT and AST, appear basically normal. As I said before, ALT is primarily a marker of biliary obstruction, and you therefore expect bilirubin to go up as well. Last, we have the picture of chronic liver disease. Since no hepatocytes are actively dying, you don't get that release of enzymes. However, if you look at bilirubin, prothrombin time and albumin, you'll see that those are deranged chronically. That's the chronic liver disease. What happens if someone with chronic liver disease has a further incident of hepatitis for whatever reason? Well, there aren't many hepatocytes left to die, so you won't get much of a release of those enzymes. Well, less than you'd expect anyway. However, the liver function will decrease, as you'd see with the bilirubin, albumin and prothrombin time. So yeah, we call this acute-on-chronic liver disease, and it's quite difficult to recognise, so make sure you know that. In fact, I'd say the two most important clinical pictures to recognise are the hepatitic picture and the biliary obstruction picture, and as I said, the main difference between those two things is ALP. If you can recognise those two, you're probably halfway there. I still recommend you read up on them and make sure that you're very good at interpreting LFTs.